everybody. It is me, Amy, the MA mentor. Glad to see you. I pretty much wrapped up, if you've been following along, wrapped up the Anatomy and Physiology series. I think I might have one or two more body systems to do, but we're going to take a quick break from those for now. And we are going to start in on probably not the most exciting for medical assistant students or medical assistants to learn about, but definitely necessary. And any of you who are out in the field know how necessary this really is. But we're going to talk more about the administrative side of our job. And we are going to start with procedural coding. So let's go ahead and get into that. There we go. Okay, so this is CPT coding or procedural coding. Now, don't get me wrong, medical assistants are not coders. We don't do this to great lengths. I call it baby coding. But we do need to understand the basics of medical coding and understand kind of the lingo involved, primarily so that we can communicate with the coders and with the people who do this for a living. So let's go ahead and jump right in. All right, so as far as an introduction goes, what coding is, what any kind of coding is basically giving each element of a classification system a code that turns it then into a coding system. Okay. So everything we do in medicine, all the procedures that are done, all the reasons for doing them are finagled, so to speak, into a classification system. And then when we give those systems a code, it turns them into a coding system. Now, usually the code consists of either numbers or letters or both. We are going to talk first about procedural coding, which for the most part is just numbers. Why we do it is it makes it easier. It standardizes things so everybody's kind of on the same page. It can be used by computers a lot easier. And quite honestly, it just makes it a lot quicker, a lot easier to just write out a code than to try and write out in words what we did so that everything can be billed through the insurance. So procedural coding, like I said, we're going to start with procedural coding. There's also diagnostic coding, which we will get to in a different video. But procedural coding is classification of the care that's given to patients. So we hear procedural in the minute, immediately you think procedure, like some type of surgery or something. Not necessarily. I mean, those are included too, but a procedure is anything we do, any type of care, any treatment, even the procedures, anything we do with a patient. Why procedure codes are used is to justify medical services, or in this case, medial services, because I typoed, to collect statistics about outcomes, and then to set the fees based on the length of time that's devoted to what we're doing, the complexity of what we're doing, and even the skill required to perform what we're doing. Now, when you say skill required, that means who's doing it, right? So it takes a lot more skill for a provider, let's say, to do something than, say, an RN. Okay. Now, for us, we can do various things. However, if the patient is not seeing a provider of some kind, you can't bill just for an MA doing things like a blood pressure check, where the patient stops by just to have their blood pressure checked. You can't bill for that because we do not have that level that is billable, so to speak. Now, everything we do at the direction of our providers, absolutely billable. But if it's just us, you can't do that. Okay. Current procedural terminology, or CPT, is what we use for this particular type of coding. The first edition was published in 1966 by the American Medical Association, still overseen by the American Medical Association. And back then it was primarily just surgical procedures, so it was what, people's minds go to when you hear procedural coding. And they translated these procedures into numeric codes. And that's, like I said, that's basically what the idea behind all of this is. It's taking a procedure, a treatment, whatever it was that we did for the patient, and turning it into a code so that it can then be billed out. If you have made it this far in the video and you haven't gone to sleep yet, please do like and subscribe. If I can ask you to please do that, especially if you enjoy this channel. It really helps me out. It means a lot to me, and it allows me to keep doing this for you. So please, if I could ask you to do that, that would be fabulous. All right, moving on. So there's levels of procedure codes. Um, we have CPT, obviously, but we also have what's called HCPCS, HCPCS, which stands for Healthcare Common Procedure Coding System. Say that 5 times fast. These are based on CPT codes, and were the basis for Medicare coding. The reason for HCPCS is primarily because HCPCS includes more codes than the CPT does, primarily due to Medicare. Medicare oftentimes covers a lot more than your typical insurance does. So you have to have more codes. Level 1 is the first level of HCPCS codes, and about 95 to 98% of these codes are used for Medicare Part B. When we get into talking about insurances and billing and things like that, you will come to know, if you do not already, that Medicare Part B is the part of Medicare that pays for the types of services we are involved in. So medical office visits, clinic visits, things like that, not the hospital side of it. Level 2 is then additional codes for procedures, injections, DME, which is durable medical equipment being things like crutches or canes, that are covered also under Medicare Part B. Here's what a paper CPT manual looks like. They are very thick, and they just get thicker every year. You can also find these codes through online, or not online. Well, they do have them online, but also through programs, oftentimes linked with your EHRs, like True Code and things like that. You can look them up that way as well. The books are still available every year, and they do update those every year. The CPT manual contains CPT codes and the HCPCS level 1 codes. There is a separate HCPCS book for those additional codes. It contains narrative descriptions and 5-digit codes for each procedure. Now, CPT coding or procedural coding, you will find, is very specific and very kind of the same, consistent, I guess, all the time, where the majority, 99% of them, have 5-digit codes for every procedure. It's always 5 digits. The manual itself is divided into 6 different sections, and you can see those right here on your screen. There is the evaluation and management section, or the E&M section, which is what we see the most of. And those start at 99201 and go all the way to 99499. Okay, that's how that's split up. There's a section for anesthesia. We don't see that as often. That's more of a hospital thing, as is surgery, radiology, path and lab, and then medicine. Medicine, we can use. Medicine can be used for things like immunizations and things like that. but primarily we deal with evaluation and management, which is what we term E&M or EM, depending on how you want to say it. So let's talk about evaluation and management. So these are codes for more service-oriented procedures, like patient exams and things like that. These are used primarily in medical offices and clinics, so that's why we tend to see these more often. Um, the code you use really depends on various factors. So whether the patient is a new patient or an established patient, whether this is a primary care visit or a consult visit, what type of service is it? Is it a routine service? Where the service was provided. Is it provided in a medical office or was it provided at, say, like an ER? In which case we would not be there. And then the complexity of the care. How involved was the service itself? There are different levels, of course, of just visit codes that are based primarily on the history. So we have kind of at the lowest level, they call that problem-focused history, where basically you're just kind of honing in or zeroing in on the chief complaint, so why they're there, and then kind of a brief history of that current illness. An expanded problem-focused, little bit more involved. We do chief complaint, a brief history, and a review of systems, which the provider does that. But it's a review of systems based on the chief complaint. Then a detailed history is a chief complaint, a more extended history versus a brief one, a review of the systems, and a family history, possibly, if one exists, relating to that chief complaint. And then the comprehensive history is like everything. It's the chief complaint, it's an extended history, it's a review of all the systems, and it's a complete family history. And the reason they kind of break them down into those sections is because, and you can kind of look at it this way and see it just by looking at it on the screen, the more that we have to get into, the more time it's going to take. And what's the old saying, time is money, right? Well, that's literally the case. The more time you have to take with a patient, the more obviously they are going to be charged. So they're going to be at a higher level of a visit code at that point. And then, of course, there'll be procedural codes added in for anything extra we do in the office. If you do an EKG, if you give an injection, if you do any type of minor procedure, those are going to be added in addition to the visit. There's some secondary factors for EM coding that can kind of help with your choice of codes. The coordination of care. Was this something are you a primary care doctor's office? You're working in primary care and you have to refer out, or are you the specialist that's being referred to? If there's any counseling involved. What exactly is the nature of the patient's problem? I mean, if it's really, really involved, complicated case, there's going to be some other factors there. And then, of course, the amount of time spent with each of the patients. So, again, it comes down a lot of times to time, complexity, skill level. Okay. Um, and again, keep in mind, as an MA, we are generally not looking these codes up, or even necessarily assigning them other than maybe the visit, um, in which case it's just a little check mark most of the time. But understanding how these levels go, it's not unusual for the billers, the coders, to maybe call us up or come to us if we're in a smaller office and say, hey, this doesn't make any sense. How long did you actually spend with the patient? What did you do? So when you understand that, you can understand why they're communicating with you and communicate more effectively back with them. HCPCS level 2. So these are the ones that are in the separate book, not in the CPT manual, because those are the level 1s, are used for Medicare and Medicaid. They are in an alphanumeric format. So they have one letter and then 4 numbers afterwards. So they look slightly different. This is the 1%. When I said 99% of them are 5 digits, this is the 1% that's not. And these are used for items that don't have CPT codes. So supplies, materials, some durable equipment, ambulance services, things like that. All right, you also see in a CPT manual, and there's an index in the back that talks about the symbols that are used. So just kind of quickly to go through these. If you see this big round black dot or circle, that means that code has been added since the last edition, and these do get updated once a year, as I had mentioned earlier. If you see this little blacked in triangle, that means the code has been changed since the last edition. If you have these little, I don't know, arrows, I guess you could say, at the beginning and the end of text, that means it's either new or revised text. So maybe the narrative has changed a little bit. The plus symbol is an add-on code. And an add-on code is a code that has to be used with another code. It can't be by itself, but it cannot also be used with modifiers. Um, and this particular modifier, which we'll talk about here in a minute, modifier 51, which is for multiple procedures. And then the little, I don't know, lightning bolt looking thing, I guess. It kind of looks like the Flash. Um, for all my DC fans out there. Uh, FDA approval pending is what that means. So if there's a medication in there that has not received FDA approval yet, that will be next to it, and usually is also a new code. Um, in recent times, I guarantee you the COVID vaccines were put in like that because they didn't get FDA approval immediately, but were being used. So therefore had codes and will probably have the little lightning bolt next to them. You don't really see it too often. Modifiers. So here's what a modifier is without getting horribly complicated. A modifier is just something that is put in addition to a procedure code that usually indicates some kind of unusual circumstance. Like there's nowhere else in the book for it. Um, and it's always a hyphen followed by a number that's added on to the 5 digit number. So for an example, 51, we talked about a little bit ago, 51 is a multiple procedures. They all mean different things, and the modifiers are in the back of the book in an appendix. But 51, for example, would be added on when there's multiple procedures that are performed by the same provider in the same visit. So um, I don't know, you have a patient that comes in. Oh, okay, here's a good example for all you that watch Dr. Pimple Popper, and I'm sure you do. Um, Not an endorsement, just saying. Um, um, a patient may come in saying, "Hey, I've got this lump," and then come to find out they have 6 other lumps. Okay, that would be a modifier situation. Because not only would the provider be removing said lump, whatever it might be, but they're probably going to have to suture it up. Or they're probably going to have to, maybe decide to remove all 6 of them. Okay. That would be a modifier situation for multiple procedures. There are other modifiers for other reasons, but it's always just something extra unusual, something that we don't see every day. So again, you don't use modifiers every day either. Okay, so when we're looking up codes, there's an alphabetic index, and then there's what they call the tabular list. And this is like with any other book. When you're trying to find something in a book, where do you go? You go to the index, you look it up alphabetically, you find it, it'll tell you what page it's on, you go to that page, right? This is no different. There's an alphabetic index, you look for it alphabetically. Um, it will usually give you a code, but it'll also give you a page number. Don't code directly from the index. And it won't give you the page number necessarily. It will give you the number, the code number, and then those are in order, but don't code directly from the index. So if you go back and you look something up and you find that it says it's 99204, for instance. Okay. Don't go, oh, yep, okay, it's 99204. There may be other factors to choose a better code. So then you go to the 99204 section on the tabular list, and then you choose the best code based on all of those other factors: location, method, time, complexity, whatever the case might be. Okay, so do not ever code directly from the index. It's a bad idea. Um, and that, I believe, hint, hint, wink, wink, is also a question on your national exam or on some national exams. All righty. Well, thank you so much for watching. That's all I have for today for CPT coding. Um, I will see you for ICD-10 coding. And just remember the difference between the two is CPT is the what, and ICD-10, when we get to that, is the why. So I'll see you for the why. And until then, take care and have a good one.